Thank you all for joining us so much today. We are going to give folks just another minute or so before we get started to enter in from the waiting room. So we will get started here in just a moment. All righty. Thank you all so much for joining today. Let's go ahead and we will get started. So thank you all so much. My name is Jessica Elliott. I'm a practice transformation advisor here at the Kentucky Regional Extension Center. And I'm joined today on this call by my colleague, Jared Deason. We are going to be talking with you about CMS's new mandatory specialty model. It's the Ambulatory Specialty Model, or ASM for short. Today's webinar is being recorded, and we will be sending out that recording in the next week or so. We also are going to have some contact information if you do have questions, but we will have a Q&A available. Just please feel free to use that chat if you do have questions for us. We do have a jam-packed webinar today. So if we do not get to your questions, we will reach out to you individually in the next day or two. So again, we welcome your questions. Please feel free to enter those into the Q&A. Now, a couple other quick housekeeping things. I just need to read our disclaimer. The information contained in this presentation is for general information purposes only and does not attempt to provide medical, mental health, or any other type of healthcare service. This presentation is not intended to be an alternative to medical treatment, and the content of this webinar may not apply directly to specific circumstances. The information is provided by UK Healthcare's Kentucky Regional Extension Center, and while we endeavor to keep the information up to date and correct, we make no representations or warranties of any kind, express or implied, about the completeness, accuracy, reliability, or suitability with respect to content. So here at the Regional Extension Center, I know we have several new folks on this call that maybe haven't attended one of our webinars before. So I want to give a quick overview of what we do at the Regional Extension Center. We work with both outpatient ambulatory physicians as well as hospitals and healthcare systems on all sorts of quality improvement initiatives. My team in particular focuses on value-based payments, that transition to that value-based care world. We focus on providing support to the quality payment program, as well as payer models such as ASM, TEAM, and the new joint replacement expanded model that's mandatory coming down the pike, as well as HEDIS measure reporting. We also do quality improvement and leadership development workshops. We address QI from a bunch of different angles. We also have some other service lines as well that are around security risk analysis, hospital, promoting interoperability, and PCMH, PCSP. So if you're interested in any of those, we've got our contact information at the end of this presentation. That feel free to reach out for questions and see how we can help you. Also, just right at the beginning, I wanted to make sure everybody knows about our upcoming annual conference. It's going to be held Thursday, October 29th. We have both an in-person and a virtual option if you can't make it in person that day, but it's going to be focusing on connecting our healthcare community, improving quality, enhancing security, and promoting interoperability. And also we're really excited for our guest speaker that is going to be presenting with us, Cameron Mills from, I believe, the 1996 basketball team, Wildcat basketball team, who won one of the national championships. Jared, correct me if I'm wrong on that, but I know a lot of folks are excited and looking forward to hearing him speak during our conference as well. And then I'll hand this over to Jared to introduce us to the ASM advisors.
Thank you, Jessica. For the folks on the call who I've not yet had the pleasure of meeting, I am Jared Deason, one of the advisors here at the Kentucky REC. And let me tell you, our team is excited to get started and prepping for this new payment model. But before we dive into the details of the program, I want to take a moment to introduce you to our team that will be supporting this work. Jessica Elliott, my co-presenter and our fearless leader over on the quality and value team here, will serve as the ASM project lead. Tabitha Hanlon, Vicky Harden, Claire Weeks, Nicole Key, and myself will serve as the advisor team that will work at the elbow with practices to prepare and perform through this payment model. With that, let's look at our agenda for today. Today's webinar is organized around three main questions that many of you may have had. First, what is this structure for the ambulatory service model? We'll start with a high-level overview of the model, then we'll talk through participant selection, the cohorts that CMS has identified. Second, how is this model different from the MIPS program? Many organizations are already familiar with MIPS, MVPs, and other value-based payment initiatives. So part of our goal today is to explain where ASM overlaps and how in those programs and where it creates new expectations. Lastly, what can the RAC do for you? We'll close today by talking about the types of support available, especially around gap analysis, quality improvement planning, reporting readiness, collaborative care arrangements, and health-related needs screenings, and how to get those implemented. As we go through our presentation, as Jess has mentioned, please ask your questions, but I'd encourage you to focus on three particular things for your organizations. Which clinicians may be impacted, what reporting infrastructure do you already have in place here, and where your current workflows may need to evolve before the model begins. Jessica, will you kick us off with this first question here? What is the ASM structure?
Absolutely. So, the ambulatory specialty model, CMS finalized this model in the 2026 physician fee schedule final rule. This model is actually pretty new and pretty transformative. This has been CMS has been signaling a move toward a mandatory payment model for specialists for a couple final rules now, and so we finally saw it come to fruition for this year. And so with this particular model, this is really designed to hold specialty care accountable for their quality performance, for their cost performance. CMS in some of those previous final rules, they really wanted to put an emphasis on physician and specialist transparency. And one of the ways to do that is to have more open public reporting of individual level performance data. That's really what CMS wants to get to, is that individual level data. And so this is the mechanism, this is one of the mechanisms that they are putting in place to try to encourage specialist participation and quality improvement and improving their overall cost efficiency. And, we've seen the evolution of this from the quality payment program, if you're familiar with that, with the MVP, the MIPS value pathways track that has been slowly evolving since 2022, 23. And this is that next step in here. But this is very unique in that this is a mandatory payment model. And we're starting to see CMS really move in that direction of making some mandatory payment models to almost put people into a version of an accountable care arrangement. And that's really CMS's ultimate end game, is to have their Medicare, traditional Medicare beneficiaries in some type of accountable care arrangement or organization of some sort. And so whether you're joining an ACO or whether you're participating in tracks like this, that's sort of a forced model, this is really where we're starting to see CMS really putting their energy and their emphasis. And it's really all about co-management. It's really getting providers and specialists, providers not hiding behind, specialist providers not hiding behind or underneath the umbrella of primary care when you're reporting in groups. It's about getting that interface, that framework of co-management activities and stronger care coordination coming together, all ultimately to reduce and drive down costs for Medicare beneficiaries. So let's talk a little bit about the implementation of ASM and the time frame that we're talking about here. So this model actually launches on January 1st of 2027, and it's going to run for 5 years and end on December 31st of 2031. Now you're going to see here that there's escalating risk that is associated with this. You're going to start out at 9%, so that's very similar to what we see with MIPS. But it's going to escalate and stair step over the life of the model to ultimately to having about 12% positive or negative risk associated with this particular model. And so that's something to consider, is that there's a little bit more skin in the game with this than what we're seeing with traditional MIPS. And we're going to talk a little bit more about some of the challenges behind this program and why some things that are similar with traditional MIPS and the quality payment program, and then also how it differs from the quality payment program. This is a really good framework and a really good chassis for CMS to use this model, this what we call cohort models, to really be able to bring in other types of clinicians into this work. So let's talk about who is required to be a part of this model, this program. We've gotten a lot of questions about this. So right now, as it stands, this model is looking at episode-based cost measures. And it's going to look at two cost measures, the cost measure for heart failure and the cost measure for low back pain. These are episode-based cost measures that were designed through the MIPS program, and they've translated this and taken this over to the ASM cohort. So you're going to have a group that's focused on heart failure and a group that's focused on low back pain, different types of clinicians. Now, how does CMS pull that together? Well, it's based on your specialty designation. So CMS is looking at your cohort assignment based on the plurality of Part B claims that are billed under a clinician's specialty code. So, those are based on the claims that you're submitting throughout the year to the MAC, and those specialty codes get assigned. Something else about this model that I want to point out is that it is for only physician practitioners. It is not for your advanced practice providers, your nurse practitioners, your PAs. It's going to be for MDs and DOs in your organization. This is also an individual level program. I want to stress that. And so this is truly a program that looks at individual provider participation. So there are two different cohorts, again, as I mentioned. So with the heart failure cohort, you are only going to have those physicians whose clinician specialty code is cardiology. It's not going to pull in any of those other cardiac subspecialties, any type of interventionalists. It's truly those folks who are those clinicians who are managing heart failure patients, who are longitudinally following them, not providing just a limited intervention, but those who are going to be managing their chronic care. And that also goes can be said for the low back pain cohort. So those specialists that are included in this low back pain cohort are anesthesiology, interventional pain management, neurosurgery, orthopedic surgery, pain management, and physical medicine and rehabilitation. So again, these are going to be, there are other providers that do help provide services around low back pain, but this is truly those specialist types who have more of a longitudinal relationship with patients who have low back pain, and that CMS believes has control in being able to coordinate and best manage those patients' care. So with that, I'm going to hand the presentation back over to Jared, who's going to talk to us a little bit about ASM participation or participant selection criteria. Jared?
Yeah, thanks, Jess. You touched on it a little bit, but I really want to take some time to make sure that we're clear on how our clinicians are getting pulled into this model. The first layer of this being that providers bill Medicare Part B claims under the physician fee schedule. That kind of gets us a large pool of providers, and it can reach various clinician types and different clinician settings. The next step of this is CMS looks at that pool and identifies clinicians based on their specialty codes that they're billing and the plurality of Medicare Part B claims that are tied to those codes. In other words, CMS is using your claims and your specialty designation to determine whether a clinician can fit into one of these two cohorts. So that gets us our pool of clinicians billing Part B with the right specialty designation codes for treating low back pain and heart failure. The next step is that clinicians have to be billing that cost measure that was the cornerstone of creating these cohorts. Both cost measures have a threshold of only 20 episodes, which is pretty low, but this connects participation to the clinician's actual volume of applicable episodes. Lastly, the clinician has to be in a selected mandatory geographic area, and we'll talk more about these locations on the next slide. But if a clinician funnels down and meets all four of these selection points, they're likely going to be required to participate. A key point that I want to make sure I highlight here is the duration of participant designation. Once a clinician is designated as an ASM participant, that designation remains through the life of this model. There's no getting away from that. Now, your reporting requirements may fluctuate, but participation status itself is intended to carry through the life of this model. If you are submitting for ASM, though, this does override your QP status or your MIPS eligibility. So that creates some planning challenges, of course. A clinician may move in and out of certain reporting requirements depending on volumes or thresholds, but that you would still need to be prepared for both ASM or other reporting requirements, like if you were MIPS eligible. In practice, that means organizations may need to monitor eligibility for both ASM and MIPS and prepare for the possibility that clinicians submit under one program, depending on what those final thresholds and CMS determinations come out to be. So really the takeaway here is don't think of this as a one-time eligibility check. This has to be an ongoing monitoring process, and you need to be prepared to submit for multiple programs with a good score. So now that we've kind of talked about how they're getting pulled in, let's look at the geographic piece of this puzzle a little bit more, the core-based statistical areas. Um, the geographic selection process, like I said, is another major part of this. CMS is using these CBSAs as their geographical unit for mandatory participation. I'm going to say CMS randomized their selection, but if you look at this map here, all of our major markets in Kentucky are covered, Lexington, Louisville, Bowling Green, and those surrounding areas. Within the selected CBSAs, 40% of applicable specialists that meet the requirements were selected. We are looking at right over 250 clinicians required to participate in the Bluegrass. That number is 6,000 nationwide. For organizations with clinicians across multiple locations, this becomes especially important. You may have the same specialty represented in different markets, but the model impact could differ depending on whether those clinicians are participating in that selected CBSA. For a readiness perspective, organizations should be thinking about three layers here: clinical specialty designation, episode volume, and that location. Next, we will move away from kind of how we're selected and who was selected, and start with what they're actually going to be measured on. CMS has built this cohort on a combination of quality and cost components related to the treatment of heart failure. On the quality side, clinicians must report all the measures listed, and at least one of the non-administrative claims measures must be submitted for scoring calculation, meaning you just have to submit that numerator denominator. One helpful thing to understand is where these measures come from. CMS looked at both MBPs and the MIPS specialty measure sets to build out on this quality category. These measures have long existed within the quality category for MIPS, so hopefully there is some familiarity here. From a scoring standpoint, each measure is worth up to 10 points. Scoring is based on decile percentages, but in this first year of the model, CMS is going to use real-time benchmarking across cohort participants rather than relying on traditional MIPS deciles. The intent is that it creates a more direct peer-to-peer comparison with each cohort. To be scored on a measure, clinicians still need to meet case minimums and data completeness requirements, which roll over from MIPS with 20 minimum cases for quality measures and a 75% data completeness. Going back to the point I mentioned earlier, you need to think about your reporting capabilities here. There's a mix of ECQMs and MIPS CQMs for the quality measures, and you need to see what your vendor supports and have a plan in place if you'll be submitting both of those measure types. Looking at cost, the heart failure episode-based cost measure is intended to capture the specialty care relationship with the cardiologist. For this measure, there is a 180-day trigger window for two related services. The average cost for this is about $9,800 per Medicare beneficiary, and an impact of around 164,000 beneficiaries per year. The category weights are pretty straightforward here. Both quality and cost sit at 50%. The low back pain cohort follows a similar structure, but of course the measures differ. For low back pain, quality measures, they are listed here. I do want to note though that the functional status change for patients with low back impairments is likely to be swapped out with another measure. There's been some issues identified with this one, and that will likely, we're thinking it's going to be the functional status outcome assessments. So just a little bit more general and broad. There's also not a administrative claims measure attached to this cohort just yet. There is likely going to be one proposed in this rulemaking cycle, but that is still up in the air and to be determined. The cost measure here is the low back pain episode-based cost measure. This is a specially adjusted cost that evaluates the cost of care to treat and manage low back pain. The episode duration is 120 to 484 days with a trigger window of 60 days for two related services. The average cost per Medicare beneficiary is $2,700 with an impact of around 441 beneficiaries per year. So let's talk about this foundational layer piece to each cohort. This slide explains how improvement activities and promoting interoperabilities fit into ASM. As you might have noticed, quality and cost being at 50% each leaves really no room for improvement activities or promoting interoperability to contribute to your final score. These categories are treated more like that foundational expectation. The model assumes clinicians are functioning at full performance in these areas. So if there's any shortcomings happening, this can result in deductions from your final score. Essentially, you can only be penalized here. I'm going to start with PI because it is exactly the same as the MIPS program. If you're unfamiliar with MIPS and this is new to you, this is a host of objectives revolving around your CERT functionality, risk mitigation, patient access to health information, e-prescribing, and information sharing. PI is actually reported at the 10 level, including providers that are not within ASM. So this kind of can help bolster your score a little bit. For improvement activities, participants are required to do both of these activities, and these activities are involved. Both of these activities have a continuous 90-day reporting period. If you have multiple providers for ASM, you can report them as a group for these activities, but they would need to be in that same consecutive 90 days. The first activity of health-related social needs screenings is asking specialists to do one of two things here. You can get in contact with a primary care provider, of these patients to make sure that the screenings are taking place, or you can conduct the screenings yourself. Personally, I would recommend doing the screenings at your location, as connecting to primary care settings will involve multiple workflows, data sharing, and connections to ensure that your ASM beneficiaries are having these done. The next activity that I think everyone is concerned about are these collaborative care arrangements. These are legal binding documents between primary care practices that share beneficiaries with the ASM participant. There are specific requirements that have to be met with these arrangements, and you need to meet at least three of the five following criteria. There has to be bidirectional sharing of information, co-management activities, which basically working together to furnish complementary care. There has to be transition in care, either patient-centered transition care action plans or transition plans. Closed looped communication between really is that process being articulated with parameters on how patients will be referred back and forth, and care coordination interactions. This is something that, you likely will want a legal department or a legal arm to be involved with, especially if there are any shared savings within these agreements. From a practical standpoint, there are things practices need to be thinking about now. Um, these are not just check the box attestations. There are serious workflow and developmental and technology pieces that need to be considered, and these are going to take time to work through. We recognize this is an area where many organizations need deeper planning and support. And this is something that, as an REC client, we're going to really be providing guidance to help put these systems into place. So now that we've kind of hammered out the structure of ASM, let's shift into how this model differs from traditional MIPS. Jessica, do you want to kick us off here?
Absolutely. We'll go ahead and get started. So first, let's talk a little bit about how they are similar to each other. So this is the quality payment program and the different tracks of the quality payment program. So there is a lot of overlap. As you can tell from, the Jared's conversation, they're the same four performance categories. It just looks and feels a little bit different as far as the weightings, and some of the flexibilities aren't there anymore. It's really this program aligns with the quality payment program in that it's trying to balance quality and cost, right? And so that is still a really important dynamic and an important principle from CMS is that their definition of value is the ratio of quality to cost. They're wanting high value outcomes for um, for more cost savings, lower cost to drive that high value care. With MIPS value pathways, again, we're starting to see with ASM, it narrows down into a clinician type, a special condition, an episode that it's built around. It's built around an episodic based cost measure. MVPs are set up in that same structure. This is just MVPs taken to a much more stringent standard. There are specialty specific quality measure sets with MVPs, and that's again, as we see the same for ASM. And then we look at the APM track of the quality payment program. You're going to see that there's a push for greater accountability for total cost of care around episodes, right? So your ACOs, your APMs, they are built around episodes, patient populations, things like that, chronic care conditions. And so you're on the hook for these total costs of care. And so that's where we see a lot of parallel with ASM. We also see that they brought in APMs, their fixed measure sets. So like the APP and the APP plus measure sets for ACO reporting of the quality payment program. We are also seeing in ASM, we have those dedicated, those required mandatory measures. There's really no flexibility in reporting, just like with APMs. We're used to a wide open menu of traditional MIPS to being able to select your measures. It funneled down more through MVPs. And then we see with APMs, you have a fixed measure set. And we also see that carried over with ASM. Let's talk a little bit about risk as well. So this component of risk with this particular program is significantly different than what we see with traditional MIPS and with the quality payment program. This is a budget. The quality payment program is a budget neutral program. This program is not. CMS actually takes 15% out of shared any type of shared savings in that APM incentive pool, they take out 15% right off of the top to guarantee that there are cost savings for CMS. So that is very different than what we've seen before with other programs, in particular with the QPP. And so, how does that impact your clinicians and your individual risk? So, this is all applied to Part B billing for the individual clinician. So, if you have a clinician who they annually bill around $200,000, they have a maximum cumulative 5-year risk at stake of over $100,000. And so that if you do nothing for all 5 years of the program, you could have over $100,000 at risk if you're drawing that full 9 to 12% penalty over the program. And you can see how it escalates. The more that you bill, the more that you do have potentially at risk if you do nothing with this program. So it's really important that we're trying to get the word out for clinicians that this can be very impactful to your bottom line. This does apply to all Part B billing. So it's not just the episodes that are tied to this particular model, those heart failure patients or those low back pain patients that you see. It's going to tie to your total Part B billing volume. And again, the billing years there's a 2-year lag similar to QPP. So the 2027 performance year, you're going to see your positive or negative payment adjustment. You're going to see that in payment year 2029. So again, very similar to how that's set up with the quality payment program. So let's start talking about a few more of these nuances and these differences. I think we've all gotten settled into the quality payment program, the MIPS track in particular. This program's been around for 9 years now. And so I think most folks are pretty comfortable with it. And so this is introducing a little bit of a curveball. There's a lot, again, that we can take from it, but there's also some nice little interesting twists to make it more challenging for us. So I've already spoken a little bit about how you have escalating risk in years 3 through 5. So that is something that is above and beyond what we're seeing with traditional MIPS. This model is truly at the individual clinician level. It's not at the tax ID level. There are some categories, as Jared mentioned, that you can report for at the group level or at the individual level for the individual performance categories. But the actual feedback that ASM participants will receive will be at the individual clinician level, and determinations are based at that individual clinician level for participation. There is no threshold to avoid penalty. So what we've seen traditionally with MIPS is that there's been, in the last couple of years, have been a 75-point threshold that you knew that if you hit that number, you were in the money. You were going to get some type of positive payment adjustment. CMS is not doing that with this program. There is no predetermined threshold. It is all going to be based on real-time benchmarking. You are going to be compared to your peers within your cohort each year, and the median performance will be that threshold between a positive or a negative percent. And so CMS actually anticipates that there are going to be a lot more folks who are drawing penalties this year or this coming year with this program than the people who are actually going to be drawing some types of shared savings and those positive adjustments. So that is something to consider with CMS already forecasting that positive payments are going to be higher simply because there's not going to be as many people that are going to be above the median. There's going to be less flexibility. There's no waiver for promoting interoperability that a lot of our small practices have depended on with the MIPS program. That is not available anymore. There are some bonus opportunities that they are allowing for small practice and solo practitioners to help offset in the event that you are not able to do your improvement activities or you're not able to do promoting interoperability. However, that then puts your ownership back fully on cost and quality. So that is something to consider about how challenging it is if you are not already excelling in your PI and your IA activities. And I already mentioned that this is not a budget neutral program. And so, again, this brings about some challenges because CMS is guaranteeing they have cost savings, again, taking that 15% right off the top. Jared, would you like to walk us through a couple others?
I'd be happy to, Jess. So this slide highlights a couple more differences here between MIPS and ASM. As we've touched on it, ASM does not employ historical benchmarkings for performance comparison. With traditional MIPS, anybody that would just submit that measure, even if they weren't being scored on it, that kind of went into that filler. And we've seen some of those deciles be smaller and shift year to year. With this model, that is not happening. This first year is real-time benchmarking, and then from there, it's going to be benchmarked by just cohort performance. So with everybody competing, trying to get the best score that they can, we expect these deciles to shift pretty high, pretty rapidly. Um, Second, ASM requires that implementation of the health-related needs screenings. And this process is something that our specialists practices may have not likely focused on in the past. This is a pretty heavily primary care focused activity that now we're going to have to figure these workflows out. Third, as we've talked, ASM mandates the use of the collaborative care arrangements. This is pushing our specialists to get more involved in the care accountability and coordination with primary care providers. Practices will need a clear way to document, maintain, and operationalize those arrangements. Fourth, once a clinician is in the ASM participant, they're going to remain as a participant through the duration of this model. This is very different from thinking about eligibility as a year-to-year issue only, where you can fall out of MIPS reporting, and then be required the next year. That's not happening here. Reporting requirements, though, can fluctuate. We've talked about it. We need to be prepared for multiple programs if you're a participant in those programs. Um, and finally, PI and IA require full participation to avoid deductions. This is very different from MIPS, where PI and improvement activities have been used to kind of help so many clinicians offset their lower quality scores that they may be seeing. In short, ASM is just less flexible than traditional MIPS in a variety of ways, and it's going to be a larger lift on our specialty providers. So kind of as we talk about these differences, let's shift into talking about some of the challenges our organizations may be facing. As we think about implementation, I believe this is where organizations will kind of spend most of their time and resources. The model on paper is relatively straightforward, but operationally, there's going to be a lot of work to be done. Uh, First, organizations are likely to need EHR or registry upgrades to meet reporting requirements. Many specialty practices are not currently capturing all the data elements necessary for quality reporting, health-related needs screenings, or those care coordination workflows. Organizations will need to evaluate whether their existing technology can support ASM requirements or whether additional registry solutions, reporting tools, EHR enhancements are going to be necessary. Second, there will likely be a need for additional staff and resources to support care coordination activities. You may need to expand care management teams, referral coordinators, social workers, or other staff that's focused on connecting patients with services and ensuring follow-ups across care settings. This very well may be a new to your practice and something that you're going to have to build from the ground up as well. Another challenge will be increasing specialty provider involvement and quality improvement efforts. Specialists are going to have to play a much more active role in quality performance, patient engagement, and identifying social factors that impact patient outcomes through ASM. And this is likely going to be a learning curve, kind of on top of whatever workflow redesign that needs to happen. I think the biggest one that everyone has questions about, and we'll have some challenges with, are those collaborative care arrangements between specialty providers and primary care services. Success in ASM depends heavily on communication, coordination, and clear expectations among care teams. And this is just another layer of that. Building these relationships and documenting responsibilities and ensuring information flows efficiently across providers may be one of the most significant operational changes associated with any value-based care model that we've seen. And finally, there are going to be first-time players on the field. There are clinicians who have never participated in value-based care before who are going to be thrown into the starting lineup and expecting to navigate a dual-sided risk care model, and that can be pretty intimidating. For those providers, that represents a dramatic shift on how performance and financial accountability are being measured from the way it's historically been. Talking through these challenges, there is a clear undertone that ASM may require investment in technology, workflows, staffing, provider engagement, care coordination infrastructure. These challenges are just the ones that kind of sit at the top of the list too. And these are things that are outside of your normal day-to-day operation challenges you may have. So if this sounds challenging and potentially a little daunting, that's because it can be. But take a deep breath. Don't fret just yet. Jessica is going to walk us through how the REC can be your trusted partner through ASM and tackle these issues with you.
So there are a lot of considerations, right, that Jared just talked about with this model that can really pose some significant logistical issues with your practice, reporting challenges as well. And so we are here to help. We understand that this is very different for a lot of folks, especially if you've never had to report in the quality payment program before. This could be exceptionally challenging. And what we do here at the REC is we provide at the elbow support. We don't just provide you a list of what you need to work on, but we actually dive down into your data, help you do data validation, making sure that your reports are accurate and correct. We help you identify areas of improvement and set smart goals related to that. We're going to help give you eligibility monitoring and guidance so that are you required to report ASM this year? Are you required to, go to QPP and report that you didn't meet thresholds, for ASM? We're going to help you navigate and strategize to set up and make yourself successful across all of your payer programs. We provide gap analysis so that you can know where you've been and help you identify where you want to be. We're also here to help you identify and make sure that you're in compliance with your collaborative care agreements. We're also here to help provide assistance and guidance in how to implement health-related needs screenings within a clinical setting. We have a lot of depth and breadth and experience in that, and so we want to be able to help share best practices with you all to help navigate these different, very challenging elements of this program. We are also offering cohort-specific learning networks for best practice sharing. So having cohorts related to heart failure and having participants be able to answer questions and share their best practices with each other so that they can learn from each other. That's some of the different services that we're offering to help support you, help support your clinicians and your overall organization in this model. We want to make sure that Kentucky dollars stay in Kentucky. And we understand that we have some of the sickest of the sick patients here in this state, and we don't want to lose any of those dollars. And we want to help you maximize your positive payment adjustments as much as possible, and really to help mitigate any sort of negative adjustment that you might receive. So if you all have any questions, please go ahead and finish putting those in the chat. It looks like we will have a couple minutes to answer questions. But I did just want to go through with you and just mention some of the other opportunities that we have outside of ASM. We are working on quality improvement tools and support. We have leadership and quality improvement workshops that we are doing where we can do hands-on lean PDSA coaching, root cause analysis, and gap analysis. We also employ rapid process improvement workshops. We can go into your organization and help you identify areas of pain points and how to strategically mitigate those. So we have a lot of different options to help fit and fill your quality improvement needs. Just reach out to us. This is our phone number. We're at 859-323-3090. You can also reach us at kyrec@uky.edu. We will get back to you with any questions that you have. If you think of something after this webinar, please feel free to email us and we will be happy to help answer those questions. So let me pop over to the chat or the Q&A, I should say. My first question is, how does this affect providers in a Medicare Shared Savings ACO? Jared, would you be able to help answer that question?
I can. And I'm going to kind of lump this in with another question that I've got in the chat. For providers assigned to ASM, do they come out of our traditional MIPS group? Um, the plan that you've got to employ here is you need to be prepared to submit either one. If that provider is required to report through ASM, they are not going to affect your ACO numbers or your traditional MIPS. They are going to get the reimbursement for their Part B billing through ASM. But if they were to fall out of being required for ASM for that year, then they would need to submit traditional MIPS if they're eligible, or if they're attached to that ACO, that they're going to have to submit their data through that ACO.
Thank you, Jared. I appreciate that. Let's see. Here's another one. How is this affected if your mid-levels are billing incident to the MD who is chosen? So that is a great question. The mid-levels will not have to do any reporting, right? They are not a part of this program. However, what they do and what they bill under that MD could add to their cost episodes to make them trigger and be eligible for the program. The care that they deliver, making sure that they are also meeting and providing and helping to support the clinical quality measures that are being reported as well. So they do play a role in helping to close care gaps with those providers who they're billing incident to. And then we also have another question. If you have 40 physicians in ASM and all complete improvement activities with the exception of one or two physicians, if reporting at the 10 level, would that still be a yes completed submission, or would one physician missing the components require a no incomplete submission for the group? Well, actually, CMS has made some clarification from the final rule in 26 in their proposed rule for 2027. Excuse me. And so CMS realized that there was a little bit of a loophole with the way they had finalized the rule to be required to submit improvement activities at the group level. So right now it's proposed that they're going to refine that, and so you can submit individually for each of the providers. Or if you do a group level attestation, you would want to make sure that each and every one of those providers they complete their improvement activities, because like you said, like in your example, if you had one physician missing the component and you're doing a group level, then that would negate their improvement activities for everyone. So in that case, you would want to report individually those improvement activities. Let's see. We also have a question around pricing for ASM support. We will be happy to reach out to you after the webinar to talk about specifics. And then finally, I have a question. Is this just for Medicare Part B? Does this affect Medicaid or Medicare HMO plans? No, this does not impact Medicare Advantage or Medicaid. This is applying to your traditional Medicare Part B. So that billing volume that you have is what that is going to apply to. Let me see if there are any other questions that we have. I think that might be all.
I'm not seeing any more.
Okay. Okay. Well, I would just want to thank you all for taking the time to join us today. Again, please feel free to reach out to us if you have other questions. If there's anything that we can do to help support you, we do want to help make sure that you succeed in this program. We realize that there are a lot of challenges, but we are here to help. So with that, we'll go ahead and close out this webinar. And again, we'll send a copy of the recording out in the coming weeks. So thank you very much for your time.